Today's topic is grown-ups need vaccinations too, keeping up with adult immunizations. The objectives of today's webinar are appreciate the role of immunizations in disease prevention and health promotion in adults. Be familiar with the different immunizations recommended for adults, particularly the pneumococcal vaccine, the influenza vaccine, and the herpes zoster vaccine. Learn the rationale behind the recommendations for these vaccines, as well as indications, dosing schedules, contraindications, and adverse effects. Today's speaker is Dr. Homer Abiad. Dr. Abiad graduated from the UP College of Medicine in 1991. He did his internal medicine residency at the University of Massachusetts Memorial Medical Center in Massachusetts, then did his infectious disease fellowship at the University of Illinois at Chicago. Dr. Abiad later earned his MPH at the University of Illinois School of Public Health. At present, he is an attending physician with the Division of Infectious Diseases, Department of Medicine of Cook County Hospital in Chicago. He is also an assistant professor with the Division of Infectious Diseases at Rush Medical College in Chicago. Without further ado, may we now call on Dr. Abiad.
Thank you, Dr. Garcia, my old groupmate, and thank you to the organizers for asking me to speak today. Hopefully you can see my slides. Can you Viber me if you can see my slides?
Yes, we can see your slides, Doc.
Okay.
Thank you.
Okay, thank you. Thank you. So, now we all recognize that vaccines are really one of the great public health achievements of the last century. However, we usually think of this in terms of childhood vaccinations. My webinar today is about how grown-ups need vaccines too, and how adult immunizations are a very important and a highly underutilized tool for promoting health, preventing disease, and for protecting public health. We already went over the learning objectives, so we'll go right into why do adults need immunization? Didn't we all get our immunizations in childhood? First of all, we know that many of these childhood vaccines have protection that wanes over the years, for instance, tetanus and pertussis, so boosters are needed to maintain protection lifelong. There are some vaccines that are specific for adults, such as the herpes zoster vaccine, for instance, which has no indications for children. Another important reason for immunizations that we don't often think of is not just to protect the person who is immunized, but also to protect others. For instance, those around us, say infants, or particularly for us healthcare workers, patients who we come in contact with who might be immunocompromised or may not be able to receive the vaccines because of their underlying disease. Again, the last thing we want is to be transmitting infections to them. So by protecting ourselves or protecting our patients, we protect those around us and around our patients as well. Finally, in adulthood, many special immunization needs arise. Different health conditions that weaken our immune systems and make us prone to different infections. Advancing age itself often makes us prone to different infections. And then certain occupations, all of us listening to this webinar, as healthcare workers, we're exposed more than most people to different infectious agents. And certain lifestyles as well. For instance, say travel to exotic locations or use of illicit drugs or high-risk sexual behaviors. All of these, for instance, expose one to different pathogens, and immunization can protect us from them. Oops. The adult immunization schedule is sort of presented similar to the immunization schedule for pediatrics that we're more familiar with. In the US, recommendations are made by the CDC's Advisory Committee on Immunization Practices, or ACIP. These recommendations are very important because often health insurance companies basically use these to decide what is covered and what is not. Basically, the recommendations are tables with the different vaccines and the different age groups with the different indications based on age group. And there's also a table where the different vaccines versus the different medical conditions, for instance, pregnancy, for chronic liver disease, what's indicated for diabetes. Of course, this is a very busy slide and lots of information there. So these are good references, but we won't be going over all of these in this webinar. I'll be focusing on a few vaccines. In the Philippines, there's sort of a similar adult immunization schedule, which is released by PSMID, the Philippine Society for Microbiology and Infectious Diseases, in conjunction with the Philippine Foundation for Vaccination. Their latest release was in 2015. In contrast, it goes through the different vaccines one by one, and then listing the indications, the schedule, and precautions and contraindications. So it's a different approach to presenting the information. Okay, first of all, let's talk about the pneumococcal vaccine. The pneumococcus, of course, is Streptococcus pneumoniae, referred to by Osler at the beginning of the 20th century as the captain of the men of death, because it was such a significant cause of morbidity and mortality. It continues to be a significant cause of mortality, even in the antibiotic era. And worldwide, the WHO estimates that there are greater than 1.6 million deaths a year. In the US, almost 500,000 hospitalizations are due to pneumococcal infections in each year, and 22,000 deaths a year from this infection. And again, this is despite antibiotics. And pneumococcus causes non-invasive and invasive disease. Non-invasive diseases, of course, the classic pneumococcal pneumonia is what we're most familiar with. Of course, there are many causes of community-acquired pneumonia, but the pneumococcus is the most common cause of this. In the US, case fatality rates are 5 to 7% despite antibiotic use, and they are much higher than this in the elderly and in the immunocompromised. Pneumococcus can also cause otitis media and sinusitis. What we don't think of as much, though, but extremely significant as well, is invasive pneumococcal disease, which occurs in two forms, bacteremia and meningitis. Bacteremia occurs in 25 to 30% of pneumococcal pneumonia, but you can also have bacteremia that presents outside of pneumonia without concomitant pneumonia. So primary bacteremia like this presents in like 12,000 cases in the US a year, and they have a higher case fatality rate than pneumococcal pneumonia without bacteremia. The case fatality rate is 20%. In the elderly and the immunocompromised, it's much higher, 60 up to 60%, and can be fulminant, presenting very much like meningococcal infection. So this patient here with asplenia presented with purpura fulminans. Again, when they come in until you get the cultures back, could certainly be a case of meningococcemia. The other form of invasive pneumococcal disease is meningitis, and pneumococcus is responsible for 50% of bacterial meningitis. And again, even in the US, with the use of appropriate antibiotics, case fatality rates are still 22% in adults for pneumococcal meningitis. The greatest risk of invasive pneumococcal disease is in the youngest and the oldest segments of our population, with the highest mortality in the oldest and the elderly, 65 years and above. This table shows incidence rates and mortality rates among different groups for invasive pneumococcal disease in the US, reported by the CDC. As you can see, for incidence rates are highest among the youngest, below 2 years old, and the oldest, above 50, particularly those 65 and older. In terms of mortality, it is the elderly, particularly those above 65 years and above, who have the highest mortality from invasive pneumococcal disease. So we'll turn now to the vaccine to try and prevent this deadly disease. The vaccine is based on the polysaccharide capsule, which is one of the main pathogenic mechanisms of the bacteria, and it helps the pneumococcus evade the immune system. The capsular polysaccharide antigens are the basis for serotyping the pneumococcus, and infection provides type-specific immunity. So if you got an infection with, say, serotype 19 pneumococcus, then you become immune to that particular serotype of pneumococcus. However, there are 90 serotypes of pneumococcus, so a vaccine is going to have to contain antigens to multiple serotypes. Luckily, not all of these serotypes are common causes of infection, and a small subsegment of these serotypes are responsible for most of the infections that we see. Pneumococcal vaccines that are available are the pneumococcal polysaccharide vaccine, which is available as Pneumovax 23, and the pneumococcal conjugate vaccine, available in the Philippines as Prevnar 13. In the US, it's known as Prevnar. In the US, Canada, and Taiwan, I believe it goes by the trade name Prevnar. First, we'll talk about the pneumococcal polysaccharide vaccine. It was initially released in 1977, containing antigens versus 14 serotypes of pneumococcus. And in 1983, it expanded to the 23 serotypes that are contained in the vaccine today. That's why it's called Pneumovax 23. These 23 serotypes are actually responsible for a good 60 to 76% of invasive pneumococcal disease. So again, they cover majority of the strains that cause invasive disease. And overall, there's about a 60 to 70% efficacy in protecting against invasive pneumococcal disease, although the data versus non-invasive pneumonia in terms of preventing just pneumonia is inconsistent. So really the utility, although often this is thought of as, oh, this is the pneumonia vaccine, it's actually not really very effective against pneumonia itself. It's really more useful preventing mortality and morbidity from invasive pneumococcal disease. Again, that's bacteremia and meningitis. Even when it doesn't actually prevent the disease, though, it does prevent the lower complications and mortality. Particularly, actually, there's good data that when it's given together with the influenza vaccine, you do lower complications and mortality. One problem with the pneumococcal vaccine is it is poorly immunogenic in those less than 2 years old. And again, this is one of the groups that are at higher risk for invasive pneumococcal disease. And so the pneumococcal conjugate vaccines were developed. Again, this is a second type of pneumococcal vaccine available. In the conjugate vaccines, the same capsular polysaccharides are linked to a non-toxic protein, and this makes the vaccine more antigenic in infants and toddlers. It was initially licensed in 2000 with 7 antigens as PCV7, and then developed, they added 3 more, and this was more in Europe, PCV10, and now it's available as PCV13. And it's recommended by the ACIP for children beginning in 2010, And in 2014, the ACIP began recommending it routinely for all adults 65 years and older. The data for adults is based on this study in the Netherlands with 85,000 adults 65 years and older, and they found that in this age group, there was a 45% efficacy versus vaccine-type pneumococcal pneumonia and 75% efficacy versus vaccine-type invasive pneumococcal disease. So the conjugate vaccine, sort of the downside is it covers fewer strains, but the upside is that there's data that it protects not just against invasive disease, but also against non-invasive pneumococcal pneumonia. One other interesting thing with the conjugate vaccine, it stimulates mucosal antibody as well, and that leads to decreased nasal carriage, which in turn leads to reduced incidence, not just in the vaccinated population, but also in those around them, in unvaccinated children and adults, for instance, and this produces a herd effect. And this can be seen in these charts. These are charts of the incidence rates of invasive pneumococcal disease in children on the left and in adults on the right by serotype from 1998 to 2007. So in children here, you can see that the PCV7 was introduced in 2000, and that brought about really a dramatic reduction in cases of the 7 strains that were included in the vaccine. At that time, though, really the PCV7 is only being given in children. However, in adults 65 years and older, interestingly, you can see the same drop in the incidence of invasive disease caused by the 7 strains included in this particular vaccine. So this is a good demonstration of the herd effect caused by this particular vaccine. Here's a table that shows the different serotypes included in the various pneumococcal vaccines. Again, it started with the PCV7. They added 3 more antigens to create PCV10, added 3 more for PCV13. By the way, in this PCV10 versus PCV13, this is sort of the controversial choice that landed prior health secretary on in sort of controversy because of the choice of PCV10 versus PCV13, but we don't have the time to go into that. And then again, the pneumococcal vaccine, the PPSV23, has 10 more strains that it protects against compared to the Prevnar or Prevnar 13. Indications. So the PISMID has a long list of indications for the pneumococcal vaccine in the Philippines. I won't go over this on this slide. There's a similar long list of indications in the US, and I'll summarize them on this slide and contrast them. There are just some minor differences. The main difference, again, for the Philippines, the recommendation by PISMID is that the pneumococcal vaccine be given to adults 50 years and older, while in the US, it's actually recommended for adults 65 years old and older. So that's the main difference. In the Philippines, nursing home residents are also included as an indication, and that's not present in the US indications. However, in common, they have all of these indications for adults who are high risk who should get vaccination with the pneumococcal vaccine. Basically, any adults who are smokers, so that's a very large population. Anyone basically with any chronic lung disease, including asthma, any heart disease, that does not include hypertension though. Any liver disease, diabetes, alcoholism, cochlear implants, and CSF fluid leaks also increase the risk for invasive pneumococcal disease. So also indications for vaccination. And then anyone with immunocompromising conditions, particularly anatomic or functional asplenia, leukemia, lymphoma, basically any hematologic or generalized malignancy, patients who've received transplants, patients receiving chemo and radiation therapy, patients with HIV and AIDS, and patients with chronic renal failure are also considered to be immunocompromised and should receive the pneumococcal vaccine. Now, which vaccines they should receive, there are some variation as well in the recommendations. The Philippine recommendations basically say you should give both the conjugate vaccine and the pneumococcal vaccine to everyone, basically. So it's much simpler in that way. Just everyone should get a dose of the conjugate vaccine and the pneumococcal vaccine. The CDC recommendations are a little more complex. Basically, the elderly, the main focus, again, adults 65 years old and older, should get the combination, again, of the conjugate and polysaccharide vaccine, as well as adults below that age group with the immunocompromising conditions that we talked about, or cochlear implants and CSF fluid leaks. Those, though, below 65 with what you can think of as sort of these chronic medical conditions that aren't particularly or not as immunocompromising as these ones, they are recommended to receive just the polysaccharide vaccine. In terms of how it's given or how often it's given, there's some further stratification as well. And you can think of these, all of these indications in groups. So there's the elderly, again, 65 and older. These ones are immunocompromised. These one I think of as anatomic high risk for pneumococcal invasive disease. And then these ones as basically chronic conditions. And we'll go over them sort of one by one. First of all, the main indication, again, the elderly, 65 and older. The indication in the schedule recommended by the CDC is the conjugate vaccine, followed by the pneumococcal polysaccharide vaccine with an interval of at least 1 year with no revaccination. So if their first vaccinations are at age 65 or older, that's all they get. One conjugate, one polysaccharide vaccine. For those less than 65 with cochlear implants and CSF fluid leaks, they similarly get the conjugate and polysaccharide vaccine, but the interval is shorter, just 8 weeks. So give them with at least 8-week interval. And then when this person gets to 65 years, you give another dose of polysaccharide vaccine with an interval of at least 5 years in between the two polysaccharide vaccines. This is one of the larger group. Again, so what about adults less than 65 with any of these immunocompromising conditions? Similarly, the recommendation is for a conjugate vaccine followed by a polysaccharide vaccine after an interval of at least 2 months. There's a difference, though. In this case, they recommend a booster. So for instance, if I have a patient with HIV who is 30, I give him the conjugate vaccine, and 2 months later, I give him the polysaccharide vaccine. Then at age 35, it's recommended that this patient would get another polysaccharide vaccine. And as with all the other groups, when this patient gets to 65 years old, he gets another polysaccharide vaccine, ensuring, though, that there's at least 5 years between these two doses of polysaccharide vaccines. The last group, again, these sort of what we think of as chronic conditions. Again, this includes smoking, so that's a lot of patients right there. Any chronic heart or liver disease, diabetes or alcoholism, they are recommended to just get a single dose of polysaccharide vaccine, Pneumovax, before age 65. And at age 65, they should get the conjugate vaccine, followed by, after at least a year, the polysaccharide vaccine, with the proviso that there should be at least a 5-year interval between polysaccharide vaccines. So for instance, if, say, a smoker who's 63 presents to his doctor and gets his polysaccharide vaccine at 63 years old, then at 65, he would get the conjugate vaccine. And then with the polysaccharide vaccine, you'd want to wait at least 5 years. So he would get this at age 68. So it's a little complicated, but again, you can always refer to these schedules, and there's a lot of information in the CDC website breaking down all these sort of timing recommendations with different charts, algorithms that are very useful. Bottom line, though, the conjugate and polysaccharide vaccines should not be given at the same visit. Again, they're separated by 8 weeks in the immunocompromised, 1 year in the elderly. The conjugate vaccine is really needed just once in a lifetime. And after age 65, only one Pneumococcus polysaccharide vaccine dose is given. In patients who are anticipating immunosuppression, you want to immunize them at least 4 weeks before so that they can build up immunity before immunosuppression before they become immunosuppressed. Administration is 0.5 ml of the Pneumovax, IM or subcutaneous, and IM for the Prevnar 13. The cost is higher for the conjugate vaccine. So in NIMS, at least, the Pneumovax is listed as 1,130 pesos. It's 3,000 pesos, 3,600 pesos for the Prevnar. Of note, the DOH does have a program that provides the Pneumovax, the polysaccharide vaccine, to indigent seniors at age 60 and 65 years. So it's a little different from the two sort of guidelines. So in this case, they give it one dose at 60 and then one dose at 65 years at local health centers. Contraindications are really just allergy to the vaccine, and adverse reactions are mild, generally just injection site pain and swelling. Next, I want to turn to another very important adult immunization, influenza. The flu occurs in seasonal epidemics every year. It's spread person to person by large particle droplets and causes anything from mild to severe illness and even death. So this is your trancazo, but it can also cause death. Increased are the very young, the very old, pregnant, immunocompromised, and those with chronic medical conditions. Worldwide, it causes 3 to 5 million cases of severe illness and up to 500,000 deaths a year. And in the US, it's estimated that it causes up to 49,000 deaths a year. And the vast majority of these deaths are in those 65 years or older. So again, it's important to particularly to protect this age group. Peaks of influenza vary geographically in the US and other temperate countries, both in the northern and southern hemisphere. It occurs in the winter, so cold, dry peaks. In tropical and subtropical areas, including the Philippines, peaks are during humid, rainy peaks, sort of during the rainy season. So in the US, again, the peak is generally in the winter, December to March. In the Philippines, it's during the rainy season, generally July to September. And this affects when we give the vaccine, which we'll go into a bit. The influenza vaccine is it's a little tricky because the virus is constantly evolving and rapidly changing. Most illness is from influenza A and influenza B strains. There are 4 strains of influenza. But influenza A in particular has a very high rate of mutation, so it's always changing. The vaccine needs to protect against the currently circulating strains. So basically, the vaccine has to keep up with the constantly evolving flu virus. So a new vaccine needs to be produced each year, and it's based on global surveillance of circulating viruses in the previous flu season. And basically, the WHO makes an educated guess and recommends the composition of the flu vaccines for both the northern and southern hemispheres. Usually, they're the same. Sometimes there's some minor differences. The production of the vaccine, though, is a long, arduous process. It takes about 6 months to produce the vaccine, and sometimes things can change during that time. So there are some years where you have a good match, some years, unfortunately, where you don't have a very good match between the strains in the vaccine and the circulating strains that end up going around the world. So for instance, for 2016, this are the recommendations from the WHO for the trivalent vaccine for the Southern Hemisphere. In this particular year, it was actually the same for the Northern Hemisphere. There are 2 different strains, influenza A strains and 1 influenza B strain in the more common trivalent vaccine. The newer quadrivalent vaccine generally has the same 3 strains and an additional influenza B antigen. So again, the different formulations, the inactivated influenza vaccine, as I mentioned, is available as a trivalent or a quadrivalent vaccine. There are a few other types that are not available in the Philippines. There's a live attenuated vaccine, which is quadrivalent, and its big sort of niche is that it's intranasal. So for those particularly afraid of needles, and again, often in kids, it's used. It's an intranasal vaccine. There's also a flu vaccine that's a high-dose inactivated vaccine that has better immunogenicity in the elderly. And there's also a trivalent inactivated recombinant vaccine that does not contain egg proteins. That's useful for those with very severe egg allergies. Efficacy of the flu vaccine overall is 50 to 60% in preventing the flu. It's a little lower in the elderly and also in years with a poor vaccine match. But even when the flu is not prevented in someone who's vaccinated, it still lowers the risk of severe disease and hospitalization. So still useful even when it's not able to entirely prevent influenza infection. There's a small but significant mortality benefit, and this seems to increase with repeat annual vaccination. So there seems to be some cumulative benefit from the annual flu vaccine. So indications, basically the CDC here in the US sort of made it much simpler, just blanket everyone 6 months of age and above, all children, all adults 6 months in age and above should get the flu vaccine. In the Philippines, it's a little more complicated. Basically how it's phrased is recommended for all adults, particularly those 50 years of age, healthcare workers, and then those with a list of different chronic medical conditions. Briefly, sort of summarize, it's basically all adults with the focus on those 50 and above, those with chronic diseases, healthcare workers and other essential workers, and those students and others in institutional settings where you can have outbreaks of the flu. In effect, actually, it's not actually too different because actually the CDC does recognize these same groups as priority groups when vaccine is limited. There have been some years when the supply of influenza vaccine is limited, and in those situations, the CDC says these are the groups that get priority. Basically, in the Philippines, it's the same thing. Again, obviously, the vaccine supply, again, there's cost to it. We don't have there isn't as much public health money to immunize universally, so the focus is really on these high-risk groups. It's an annual vaccine because, again, the composition of the vaccine varies each year. And apart from that, the protection wanes. The protection is strongest in the first 3 to 4 months and drops particularly 6 months after immunization. Which is why timing is important. So again, in the Philippines, the peak of influenza is during the rainy season, so it's recommended that the flu vaccine be given in April and May. In the US, the peak is in the winter. Recommendation is for September or October, basically as soon as the annual flu vaccine is released, which is usually in the fall. It's recommended, though, that the vaccine should continue to be given to patients throughout the influenza season. So if someone comes in, like in the US, like in January, February, we'd still immunize them. Similarly, in the Philippines, even if someone comes to the clinic, in August, it's still recommended that they get the flu shot. And it can be given at the same time as other vaccines, or they use a different site. It can be given to patients with minor respiratory infections, even if they are febrile, although in patients with moderate to severe acute illness, it may be postponed, but just make sure they come back and get it when they're better. The annual dose is 0.5 ml given intramuscularly, and these are the different vaccines available in the Philippines. Generally, 600 pesos for the trivalent inactivated vaccines, and a little more expensive for the quadrivalent vaccines. And so influenza vaccines, along with pneumococcal vaccines, those are the two adult vaccines that the Department of Health does provide, I guess technically for indigent seniors at health centers. Contraindications are really, again, just infancy in infants less than 6 months, and then severe life-threatening allergy to the flu vaccine primarily. Egg allergy used to be sort of a contraindication, but the current recommendation of the CDC is anyone with the indication for the flu shot, even if they have egg allergy, the amount of egg protein in the current vaccines are such that the recommendation is that they should still receive annual influenza immunization. So bottom line, history of allergy to the flu shot, you can't give the flu shot with a severe allergy to the flu shot. History of allergy to egg, you can give the flu shot. So that's the current CDC recommendation. I don't have time to go into Guillain-Barre, but basically adverse effects it's well tolerated, mostly just arm soreness and very rarely Guillain-Barre syndrome again, but that's extremely just case reports. One important thing I wanted to mention is in healthcare workers, influenza infection in staff and in patients in healthcare facilities are common. So the CDC and multiple other professional organizations recommend mandatory influenza vaccination in healthcare workers. So many, if not most, hospitals, at least in the US, say, for instance, all of the hospitals I work at, influenza vaccine is mandatory for all employees unless there's some documented medical contraindication. And they do try to get to 100%. I think last year at my hospital, they got to 95% plus. And it's been found to really be effective. There's actually a randomized controlled trial of 12 hospitals in which one arm, the healthcare workers were offered flu shots. The other arm, they were not offered. And in the arm where they got offers of flu shots, they found a lowered inpatient mortality of 10% compared to 17% in the hospitals where the healthcare workers were not offered flu shots. So by getting the flu shots as healthcare workers, we really do prevent mortality in the patients we serve. Okay, lastly, I wanted to talk about the shingles vaccine against the Varicella zoster virus. VZV, as we know, causes chickenpox as the primary VZV infection, presents with vesicles all over, and there is now a Varicella vaccine to prevent that. The other presentation of VZV is herpes zoster or shingles, which is the reactivation of VZV that has been latent, lying dormant in sensory root ganglia. The vesicles in this case are unilateral over one or several dermatomes, and now there's a herpes zoster vaccine to prevent zoster. It's actually the same virus, the same live attenuated virus in the varicella and zoster vaccines, but in a much higher dose in the zoster vaccine. Now, how big a problem is this? It's estimated that the lifetime risk of herpes zoster is about 30%. In the US, it's thought to cause 1 million cases annually, and the incidence increases with age, which goes along with the waning cell-mediated immunity that comes with increasing age. Particularly, this increases after age 50, and it's estimated that among those who live to age 85, about half will have had an episode of zoster sometime in their lifetime. So overall, it's 30%, but if you live to 85, you'll have a 50-50 chance of having had an episode of zoster. Risk factors, again, apart from age, we do see slightly higher rates in women, and definitely higher rates in immunocompromised patients. Autoimmune disease, those some chronic steroids, TNF inhibitors, chemo, transplant, HIV, malignancy, chronic lung and kidney disease, all increase risk for herpes zoster. The most common and debilitating complication of zoster is postherpetic neuralgia, which occurs in 18 to 30% of zoster cases. It's basically defined as persistent pain that lasts for more than a month after resolution of the rash. This can be very debilitating. It can last in some cases for months, sometimes even years, and can disrupt sleep, mood, work, and activities of daily life. The incidence of postherpetic neuralgia increases with age. It's about 6.9% in 60 to 69 years old, and higher than that in this particular study in those above 70. And this graph shows again that both zoster in the light blue and postherpetic neuralgia in the darker blue increase significantly with age. Again, mainly in those above 50, and then again in the much more elderly, you have a much higher incidence of postherpetic neuralgia as well. The zoster vaccine to prevent shingles and postherpetic neuralgia is a live attenuated vaccine available as Zostavax. It's the same strain used in the Varicella vaccine again, but it's 14 times more potent. The main data for the utility of this vaccine comes from this study where there were 38,000 patients 60 years old and above, and they found decreased zoster incidence by 51% and decreased risk of postherpetic neuralgia by 67%. The efficacy, though, decreases with age. In those 8 years and older, it drops down to about 18%, although it still reduces the severity of the infection and of postherpetic neuralgia. So even if it doesn't entirely prevent zoster, it still reduces severity in the very elderly. Protection, though, wanes after 5 years. And there is no data and no recommendations on revaccination. So currently, it's really just one lifetime dose. So the recommendation is a single dose in adults 60 years and older. Again, this is the US recommendation. In the Philippines, the recommendation of PISMED is for one single dose in adults 50 years or older. And it's, so you can see it's a little different. It's important that this is given regardless of history of chickenpox or zoster. So whether or not they remember getting chickenpox, or whether or not they had a zoster episode in the past, it doesn't matter. The age is the only thing really that's used as an indication for recommending this vaccine. There's no upper age limits recommended for all eligible, including those above 80. Why is there a difference in the recommendations? So basically in 1996, the US FDA licensed the vaccine for those 60 and above. In 2011, the FDA expanded this to include those 50 to 59 years old based on data that it reduces risk of zoster by 70% in this age group. However, the risk of zoster and postherpetic neuralgia is actually lower in those 50 to 59 compared to those 60 and above. And efficacy, again, wanes after 5 years, which is why the CDC does not routinely recommend Zoster for those aged 50 to 59, only for those 60 years or older. Again, because the thought is if you give it at 50 to 59, by the time they get older than 60, when the risk is even higher, the protection will be waning. Those at 50 to 59 can still be considered on a case-to-case basis for vaccination if you anticipate poor tolerance of zoster, like someone who's anticipating immunosuppressive therapy, someone with pre-existing chronic pain or chronic severe skin conditions. Contraindications are just allergies to the vaccine components. And again, because this is a live vaccine, any severe immunosuppression, including high-dose steroids, basically the equivalent of 20 milligrams prednisone per day chronically, any use of TNF inhibitors, chemo, or radiation therapy. Hematologic malignancies, transplantation, HIV with CD4 counts less than 200, and pregnancy are also all contraindications to this live attenuated vaccine. It's a single subcutaneous dose in the upper arm. You should avoid antiviral drugs for 14 days after, because again, it's a live vaccine. You don't want to kill the vaccine that you give by giving antiviral drugs 2 weeks, within 2 weeks. If immunosuppression is anticipated, vaccinate at least 4 weeks before that. And if the patient's on chronic immunosuppression, if they get off of that immunosuppression, you can vaccinate, but if they were on steroids, after they stop, wait for 1 month before giving the zoster vaccine. For chemoradiation, wait for 3 months after they're done with their therapy before giving the zoster vaccine. Only mild injection site reactions are the main things to watch out for. And maybe the biggest sort of logistic barriers to widespread zoster vaccine are, one is that it's the only routinely recommended adult vaccine that has to be stored frozen. So as opposed to most of the other vaccines are stored refrigerated, this one's a frozen powder. And it's after it's reconstituted, if it's not used, the manufacturer recommends that it be discarded after 30 minutes. So it's a little difficult to keep in stock that way. Furthermore, it is the single most expensive adult immunization. So the Zostavax in the Philippines is listed as, has a list price of 7,500 pesos. Okay, moving on, just a few more topics before I finish. I just wanted to mention again the recommendations for immunizations for healthcare workers. So this is something important for all of us, for all of you listening. Again, not for our patients, but just for ourselves. There are recommendations that we protect ourselves and also protect our patients by being immunized. Again, it's important that we're all immune to hepatitis B, and if we're not, we should have received the hepatitis B vaccine. We should all be getting the annual flu shot, a one-time Tdap, and a tetanus booster every 10 years. Also, we should all be immune to measles, mumps, and rubella, as well as varicella. For very specific healthcare workers at risk of repeated exposure, the meningococcal vaccine and rabies vaccine are also recommended. But the main ones are these ones for all healthcare workers. Okay, lastly, before I finish in the last few minutes, I want to give some examples of just sort of thinking through a few cases of adults, for instance, and what vaccines might be recommended. Because again, this isn't something that we often sort of think through certainly not as routinely as we do in kids. For instance, and I'm thinking of, trying to sort of put this as someone, say, for instance, rather than a patient, So I think of, maybe a tita of yours. Okay, so let's say here, think about Tita Belen. She's 68 years old. She has hypertension. She has osteoarthritis. She's a retired teacher. Basically stays at home but does visit the grandchildren. Are there any adult immunizations that she should get? So what we look at, for instance, look at the schedule for adult immunizations. We look at, so she's in this age group. And because of that, these are the vaccinations that she should get. She should get the flu shot. She should get Tdap or tetanus. Varicella, not as important, especially in the Philippines, where prevalence rates or seroprevalence once you get to adulthood is very high. And then the Zoster shot, again, is recommended if she can afford it. And then again, pneumococcal shot. So for Tita Belen, it's recommended she should get an annual flu shot, again, in April or May. She should get the pneumococcal vaccine, the conjugate vaccine, and then followed by the polysaccharide vaccine. And then she should also get, if she's not received since childhood, Tdap, and then a tetanus booster every 10 years, as well as the Zoster vaccine. Again, that's just in terms of the recommendations. Again, whether I would put them in sort of this order of priority, because again, in the Philippines where everything is out of pocket and the cost of these vaccines are very important considerations, then at least I would put them sort of in this order of priority. Similarly, second quick case, Dr. De La Cruz could be one of us, 51-year-old male with high cholesterol. He's a smoker, though, smokes half pack per day. He's a general surgeon. What should he get? So his age doesn't put him into a specific recommendation, although, again, all adults should get the flu shot. So there's that. So being a smoker, though, makes him prone to pneumococcal, invasive pneumococcal disease. So he should get the pneumococcal vaccine. Then again, as a healthcare worker, there are vaccines he should get. So he should get an annual flu shot. He should get the Pneumovax, the polysaccharide vaccine, although when he turns 65, he should get the conjugate and then the polysaccharide vaccine. Then he should get Tdap and TD booster every 10 years. And again, as a healthcare worker, he should be immune to Hep B, measles, mumps, and rubella. Lastly, in references, so instead of giving you websites, again, these are sort of the Google terms to look up for the CDC or ACIP immunization schedules. Just Google CDC adult immunizations, and the first search result should be these schedules. For PISMID, just for the Philippine recommendations, just Google Philippines adult immunization schedule. The first one that comes up is the PISMID schedule. The CDC Pink Book has a lot of more detailed information about all of these vaccines, epidemiology, efficacy, side effects. So it's also a useful resource. Just Google Pink Book, say for instance, Pink Book, meningococcal vaccine, and the first search entry should be the relevant one. Lastly, there are also on the CDC website vaccine information statements that are also very useful, basically frequently asked questions for the different vaccines. Interestingly, there are also some they're also available, many of them in Tagalog, like this one for influenza. Ano ang kailangan mong malaman tungkol sa influenza bakuna? So again, it would need some modification because they're really written for US epidemiology, but most of it is similarly relevant to the Philippines. Last, I'd like to end with just a quote from this hero of medicine, and particularly infectious diseases, Louis Pasteur. When meditating over a disease, I never think of finding a remedy for it, but instead a means of prevention. And again, I'd like us all to think something we don't do as much, but of prevention through vaccination in adults as well. Thank you, and I hope that leaves a little time for questions.
Thank you for that insightful lecture, Dr. Abiad. We now have 87 logged in to go to webinar and 8 through live streaming. Before our question and answer portion, we would like to thank today's sponsor, MSD, and our media partners, the Philippine Daily Inquirer and the Filipino Doctor. Okay, we have several questions for Dr. Abiad. So, Here's one from Dr. Christina Camera. I see many elderly patients with shingles. You said this vaccine is recommended for all above age 60, regardless of previous shingles history. The patient's most common question is, how soon can I get the shingles vaccine after getting the shingles outbreak itself?
Thanks for that. Yeah, very interesting question, Tina. I believe, generally I would say as soon as the acute episode of Zoster has completely resolved, they should be eligible for the vaccine. There isn't any particular need, as far as I'm aware, of postponing it or waiting any particular period of time. Because again, the sooner they get it, the sooner they can be protected. There we go. The sooner they can be protected from further episodes of shingles.
Okay, thank you for that, Homer. There's another question here from Catherine Haynes. She asks, for those adult patients that are underweight, what is the recommended dosage for the flu vaccine? Do you use the pediatric dose or the adult dose?
Yeah, basically the recommendations for adults are regardless of weight. It's the same, 0.5 ml. We don't adjust for weight really. So yeah, that's regardless of weight, whether they're underweight or here we have 300-pound patients. They also get the same 0.5 ml dose.
Okay, so if it's an adult age, you give the adult dose.
Yes.
Another question for Dr. Homer. In outpatient clinics, should patients with shingles be isolated?
So in outpatient clinics or basically any healthcare settings, it depends on where the shingles is. So basically, the most common area that's affected by shingles, of course, are the thoracic dermatomes. Those are usually covered by clothes. So as long as the shingles vesicles are completely covered, that's sort of enough protection in the healthcare setting. As long as the patients are immunocompetent. So, but for patients who are, so either if the vesicles are exposed, for instance, herpes zoster ophthalmicus, where it's on the face, where obviously it's hard to keep that covered the entire time, those should be isolated from other patients. In the inpatient setting, here, at least in the US, they're placed on contact and negative pressure airborne isolation. The same precautions also for any shingles in a patient who's immunocompetent, who's immunocompromised, say a patient post-chemotherapy, who's receiving chemotherapy, who has shingles on the trunk. So in that case, even if it's covered, even if the lesions are covered, if the patient is immunocompromised, there's a higher risk that they might still be shedding the virus. So for immunocompromised patients with any shingles in the healthcare setting, at least here, the recommendations are for contact and airborne isolation.
Okay, thank you, Homer. I have a question for you. You mentioned that for the flu vaccine, there is a specific flu vaccination for those with egg allergies. Homer, if I have a patient that I do know has an egg allergy, I know that you need to give it pa rin, but do I have to give extra advice with regards to a possible hypersensitivity?
Yeah. So the recommendations have actually really evolved. In the past, actually, the recommendations, for instance, were to give it, but they have to be monitored for 30 minutes afterwards. But now actually the current recommendations have gone beyond that. They actually pretty much say you can just give the vaccine. Again, if someone though, I mean, in the real world, if someone told me, yeah, they had a very severe egg allergy, yeah, I'd probably sort of say, okay, you got the shot, just wait there first, So keep them around first for a little, especially the severe allergies anyway are more, you'd have an immediate reaction. So it's not like you expect them to be going home and then have anaphylaxis much later.
Homer, if you give your flu shot, do you ask for a history of egg allergy?
So yeah, here sort of just routinely they still do ask, because there's this sort of we give there's a sort of a checklist, yeah, asking particularly about, well, more important again is the history of allergy to prior influenza vaccine. But yeah, sort of the routine checklist, sort of just so you're aware of it, does ask for history of egg allergy, just so you know what to anticipate, even if you don't necessarily, it might not necessarily change what you do, even if you're still going to recommend the flu shot, still going to give them the flu shot, but maybe you sort of, again, you might watch out a little more closely.
Okay, thanks, Homer. There's another question here from Tina. You have recommendations about when to give the live attenuated vaccines in those taking chronic prednisone or on an immune suppressant. I have a lot of patients on etanercept and adalimumab. Any specific recommendations? How long to stop the TNF blockers prior to giving the live vaccines?
Right. So again, for those, at least the recommendation for steroids, and I would expect for the TNF inhibitors as well. You would wait. Generally, sort of, the recommendation is for 1 month. For those medications, and then again for chemotherapy, systemic chemotherapy, cancer chemotherapy, it's 3 months. But for the TNF inhibitors, it's 1 month should be adequate for waiting before giving the live vaccines.
Okay, thanks, Homer. Another question. Can a 58-year-old patient taking anastrozole be given PCV13 or PPSV23?
I'm not familiar with anastrozole. Google, quick Google. What is anastrozole? Who was that? Is that Tina also?
No, it's
was
not.
that Tina also who asked?
Or Maria Teresita Pinzon.
Oh, it's also it's also a TNF. Is it? Oh, anastrozole.
Would you know what that is, Matthew? Yes.
It's a medicine for bone metastasis.
For bone mets, the Homer.
Bone mets. Not from because yeah, there certainly especially with cancer therapeutics now. Obviously, there are some. Our standard cancer chemotherapy is, of course, very immunosuppressive, but there are some that are less so. So I'm not that familiar with anastrozole in particular, but.
So if it's an immunosuppressant.
Yeah.
It's a hormonal
so
therapy.
I would have to look it up. Yeah. So if it's hormonal, yeah. If it again, unless it causes, if it doesn't cause severe immunosuppression, yeah, live vaccines can be given. For instance, for rheumatologic medications, for instance, things like methotrexate sort of are less immunosuppressive, and you can still give live vaccines. Again, the TNF inhibitors or chronic high-dose steroids, you can't. So sort of there's a spectrum among immunosuppressive medications where there's some that are milder, where you can still give the live vaccines.
All right. Another question. In patients with tuberculosis, can we give the flu and the pneumococcal vaccine?
Yes. In fact, the TB, I think in the Philippine recommendation is listed as one of the chronic pulmonary conditions. So it's actually not a contraindication. It's actually an indication for these vaccines. So you don't really expect any untoward effect from their having underlying tuberculosis, but certainly having a chronic pulmonary disease like tuberculosis, they're actually more prone to these infections. So yeah, you actually should this shouldn't deter you from giving it. They should actually encourage you to vaccinate with the pneumococcal and the influenza vaccines.
Okay, thank you. From a classmate, Dr. Ami Bella. For an adult about to travel and wants to get Zoster vaccine, what is the latest time-wise can you administer the Zoster for this to be effective?
So for most of these vaccines, generally you want to give at least a month. Now, for the Zoster vaccine, though, again, it's not really that relevant, though, for travel, because remember, the Zoster, it's for latent vaccine, generally that's in your body already. So maybe, though, so someone sort of, if you're talking about someone, say, in the US, who's traveling and is afraid of varicella, and as an adult, I mean, you could check immunity, whether they're immune, if they have evidence of immunity, if they've been vaccinated against varicella, if they're immune, and might consider varicella vaccination, but not the shingles vaccination, because again, the shingles vaccination, again, the focus is really more on the vaccine that you already have latent in your body. So it's not really recommended necessarily as a travel vaccine.
Okay, thank you. Here's another question. What could be the possible intervention if you encounter a patient who was given the PPSV 23 and the PCV 13 at the same time? Do we need to revaccinate that case?
Yeah, the recommendations from the CDC for those, if they're, again, it's recommended not to give it, but if you give it at the same time or within, shorter than, again, like that, there's at least 8 weeks, for instance, the recommendations are still not, basically you don't necessarily have to revaccinate. I mean, it's not dangerous, and B, so there really aren't recommendations in that case for revaccinating. That being said, again, these are just sort of general guidelines. If someone was really sort of particularly immunosuppressed, I would certainly consider revaccinating them. Maybe down the road anyway. They would need a pneumococcal vaccine booster, say, after 5 years anyway. But yeah, I wouldn't necessarily revaccinate, within 8 weeks.
Okay, thank you very much, Homer. Thank you for that engaging discussion. And so now to summarize, we learned that pneumococcal disease is a serious disease that causes many complications, some leading to mortality. There are 2 vaccines available for us, the PCV13, which protects against both invasive and non-invasive disease. We have the Pneumo23, whose utility is more for the prevention of mortality and morbidity from bacteremia and invasive disease. The recommendation is to give PCV 13 first, and 1 year later, we give the PPSV 23 with varying recommendations for those who are immunocompromised. For the flu vax, the recommendation is to give it for everyone 6 months or older, yearly, The best time for the Philippines is to give it April to May, and in the US, it's September to October. The Herpes Zoster vaccine is also available and is the same type as the Varicella vaccine, but with 40 times more potency. It reduces severity of the attack and postherpetic neuralgia. In the Philippines, they recommend a single dose given at 50 years old and older. And in the US, it's 60 years and older. And that cost is 7,500 per dose. The other adult vaccinations recommended are Hep B, flu, Tdap, and TD with their vaccinations every 10 years. And adults should be immune to MMR and varicella. We should also get the meningo vaccine and the rabies for those who are predisposed for for these conditions. So thank you very much, Homer. That was a wonderful lecture. We're gonna get some vaccination soon.
So go out and get your vaccine.
Yes, you can get it, Homer. You got us scared. No, I'm not scared. Concerned.
30,000 words.
It's 50 years old and above. That's our class. 30,000.
Yeah.
Thank you. After this session, an email containing a survey link will be sent to you. After answering the survey, your certificates will be sent to you. Please answer the survey so we can assess our webinar and address more of your preferences and give you materials from this session. Thank you for joining us. We would like to thank our sponsor, MSD, and the Philippine Daily Inquirer and the Filipino Doctor for their support as our media partners. We hope to see you again in our upcoming webinar on December 7, Wednesday, 12 noon to 1 p.m. Manila time with speaker Dr. Lynn Lucena on seizures, early recognition, and management. Please invite your colleagues to join this continuing monthly CME webinar series. For upcoming webinar schedules, you may check our Facebook page or subscribe to our mailing list by visiting the links written on your screen. For questions and comments, you may email us at upmedwebinars2016@gmail.com. And if you missed some of our webinars, you may subscribe to our YouTube channel. On behalf of UPCM Class 1991 and the UP Medical Alumni Society, we also thank our collaborator units, UP Manila Information Management Service, National Telehealth Center, UP College of Medicine Postgraduate Institute of Medicine and Medical Informatics Unit, BOSTA-STI, and Ms. Charisse Orhalo of UP National Telehealth Center, our host. This is Dr. Grace Amante Garcia, together with Dr. Homer Abiad, Dr. Marisha Recto, closing this session. We hope you have learned a lot from today's webinar. The UP Medicine Webinar Team 2016 of Class 1991 invites you to join us again on December 7, Wednesday at 12 noon Manila time. Have a great week ahead.